Good morning, everybody. Happy May 1st. We turn over the calendar to a new month which is special to me. My wife's birthday is tomorrow. My birthday is a little later on in May. So I always enjoy May. May is a good month. Usually means, we're kind of moving out of spring into summer and looking forward to all the activities and, adventures that brings. Obviously, this is going to be an interesting summer, as we try to figure out how to navigate with the coronavirus situation. As many, of us, I know there's a big rush on the beaches last weekend as the weather warmed up, and California is looking at clamping down on that and closing all the, beaches and state parks, etc. So again, not fun, not great for what we all want in terms of some recreation and time in nature in that regard, et cetera. But on the other hand, I just remain really appreciative of California for being really proactive and really aggressive, and on the flip side, continue to be amazed and frustrated at some of these other places across the U.S. that are being much more cavalier. And we're seeing a lot of discussion in the media and the um, Twitter sphere, et cetera, about, okay, great job. We seem to have done a reasonable job finally about, quote, flattening the curve and getting to the point where we're slowing down the rise of cases. And everyone's saying, well, now everyone wants to just open everything up. And what do you expect? Is the curve going to go up, or is the curve going to go down? And I think we all know the answer to that. So again, a time to remain careful and vigilant. Dr. Asfar will go through some of the numbers and data and updates today for us as well. We have the rest of our team members. Nick Loffrey will be with us again today for some Qigong. And again, I hope you all are doing okay out there. I have a quick update, Ramsey. Actually, let me do a quick screen share first, if you don't mind.
Okay. No, not at all.
We, about a month ago, 5 weeks ago, as we are settling into the first wave of adjustment with the coronavirus situation, and the kids were home from school, and we said, my son said, "Hey, let's get chickens," and we said, "Great, that sounds wonderful. That would be a good addition. It'd be a fun project." And so that was about 7-8 p.m. we had that discussion, and then the kids went to bed, and 8 and 9 p.m. I'm thinking about, I wonder if chickens carry coronavirus, and did a little bit of research and remembered back to the fact that China had mass slaughtered a bunch, millions of their chickens for concern around that risk. And in fact, chickens can carry coronavirus. And so I felt like we were overreacting a little bit, but woke up in the morning and we said to him, because there's that risk, and because it means us going out and going to the feed store, and who knows who handled the chickens, et cetera, and how would we even think about how to clean them off and all these issues, I'm sorry, but it's probably not a great idea, not a great time right now. There was some disappointment, upset, frustration, and then quickly he pivoted to, well, let's just get chicken eggs. Let's buy fertilized chicken eggs, and so he embarked on this project for the last month, where he's been like sort of this mad scientist slash, brooding hen parent of taking care of this group of eggs. And just yesterday, we started to see the first little peephole coming out into one of these eggs. And so we rearranged the entire living room, moved all the couches out of the way, brought in a mattress, put it on the floor so that he could sleep there the night. And sure enough, by this morning, we have our first visitor. So I want to introduce you guys and show you our newest addition to our family. Everyone see this little guy?
Mm-hmm.
Pretty cool. So we're excited parents and grandparents over here, and there's 9 more eggs in there. We'll see, how many of them make it through. Hopefully, all. Um, but just feels like a silver lining in this whole thing on our end right now. This opportunity for him and for being home, being able to watch over these guys and raise them, and it wouldn't have happened. None of this would have come to a pass had he been in his normal schedule, normal school schedule. And so again, just kind of hoping that we all have the opportunity to have little experiences like this of yes, this is hard, but also there's some potential silver linings and good things that are coming out of it and that are going to come from it. So with that, Ramsey, I'll let you take over.
All right. So I'll share my screen and give you guys a little bit of an update. So a lot has happened this week, as in most weeks in coronavirus world. Just to point out our website at ccfmed.com/COVID-19, we have the videos posted here. Christy has kindly worked on getting those all up, and lots of resources and a website registration link as well. So keep that in mind. Sandra, interesting that you pointed that out about chickens and coronavirus. Remember, coronaviruses have been circulating for a long time, and there's many that commonly infect other species, especially bats, but also chickens. My cousin is a distributor of coronavirus, he's of veterinary medications and vaccines in the Middle East, and he is involved in distributing coronavirus vaccines for chickens. And they've been doing this for years. So that's good news when I realized that. I'm not very up to date in all what's going on in the veterinary world, but that there is already a vaccine candidate, and lots of, here's a little thing from the Food and Agriculture Organization, that's a UN body, FAO, talking about infectious bronchitis, and the vaccine for chickens is specifically for infectious bronchitis, which can cause problems in flocks of chickens. And so we know that vaccines can work for coronaviruses, and they provide relatively long-lasting protection. So to continue with what's now a tradition, just a quick update on the number of cases. The US has about a third of total worldwide confirmed cases. Pretty impressive, I must say. And we are up to more than 3 million infections worldwide. This is the US map. And as you can see, oops, it's quite sensitive here when I toggle around. Lots of activity at the coasts on both sides. We have quite a few places in California, but not quite as much activity. Although if we continue to see what we've been seeing in Huntington Beach, which and other parts of Orange County beaches, which Governor Newsom wasn't too happy about, he shut them down for the weekend. So we might keep that in mind. Uh, Georgia, I want to point out in particular, has quite a bit of activity, and they're the state that opened up first. We'll talk about that more. Louisiana, lots of activity, obviously, in the Northeast. And one of my colleagues working in Massachusetts is just quite overwhelmed right now in central Massachusetts, and lots of parts of Michigan, Detroit, we're having activity as well. So wanted to see the curve, show you if it's flattened and how it's flattened. So it seems that it's persistently flattened and perhaps on the downtrend in the United States overall. And as Dr. Schweig said, will this continue and persist as we start to reopen? We don't know. It will be interesting to find out. And it's always interesting to see where COVID cases are increasing. And you could see that still the United States is one of the hot areas. Lots of activity in Central America, in Southern America, especially Ecuador and Guayaquil, which is the coastal city where largest commercial city. It's a commercial center of Ecuador, and a lot of trouble there with lots of infections going on due to transmissions originally from Spain. Uh, just to show you projections, in the United States, we're projecting that we're not going to exceed capacity. I like to look at ICU beds here, and all beds, we're definitely below capacity on a country level. Uh, and I'd like to also look at what's happening in Georgia. So in Georgia, they were uh, peak deaths were a little while ago, but 3 days since peak resource use on April 8th. Will that change? This is the curve to watch, everybody. Georgia is the one that opened up first, and they are, close to ICU bed capacity. Remember, the shaded area represents the confidence range of the projections. So they might be in trouble. They might not. We're going to have to find out. Certainly, if you have a friend from Georgia, tell them, you know, maybe wait a while before you visit. I'm just kidding about that. I always like to throw in a little bit of international things and what's happening in uh, France. This is an article that came out yesterday. So saying that the coronavirus could have started circulating in France in mid-January. So again, we're learning that the virus has been circulating earlier than we initially thought, but not like some sort of conspiracy theorists suggest in November. I think that's not very likely. At least it's not borne out by good evidence. A great article in the New York Times yesterday. I want to spend some time delving into this because it's showing how coronavirus spreads and mutates, and that has some considerations for a vaccine. So here you have the coronavirus genome. So this is an RNA virus. Remember that it's composed of multiple nucleotides, these letters, A, C, G, and U. So it takes 3 letters. It's a little confusing, but these 3 letters, each group of 3 letters can produce an amino acid. So the so and these 3 letters code for 26 different uh, amino acids, and there's some overlap because there's more than 26 different combinations. So you can have a mutation that actually causes a change in that amino acid. And amino acids are the building blocks of proteins, and proteins do most of the work in the body. So these are the genes. And here we have the genome from called Wuhan Hu1 that's collected on December 26th from an early patient. So we're comparing that genome to other genomes. And uh, copying the gene, the virus has this uh, protein that it carries that can copy the genes, and it's a little sloppy. It makes some mistakes. It does have a proofreading mechanism, but it's a little sloppy. The HIV, um, the virus that causes AIDS, HIV, does have an extremely sloppy system, and that's why it's very hard to copy or to make a vaccine against that because it has lots and lots of mutations. But in terms of overall viral sloppiness, COVID or SARS-CoV-2, which is the name of the virus, is not very sloppy. So here's another genome collected from a patient on January 8 in Wuhan. You can see only 1 letter changed, okay? And then 1 descendant, 2 more mutations on February 27th. There's a couple more changes. Again, uh, this mutation happened to also change an amino acid. This one did not. So this is a more significant mutation, but the virus can survive. And this one also changed an amino acid. So if you look at, uh, maybe they thought that that virus came from Wuhan and then went to Guangzhou. Then when do mutations matter? So a silent mutation, here you go. This is that explanation I was trying to give you. So if the 3 letters are A, C, and U, that might make an amino acid called threonine, which we use a T to label. And if it changes ACA, that's also threonine. ACC is also the same, and ACG is also the same. So these are silent mutations. They're not causing any changes in the amino acids that build the proteins. But if an ACU changes to AUU, that changes the threonine, that amino acid, to a different one, isoleucine. I don't mean to be a lecturer on biochemistry, but a lot of you are interested in the more detailed approach. I thought we'd go a little bit more detailed. And you can refer to this article in yesterday's New York Times. So the amino acids can cause sometimes a change in protein. So these are called non-silent mutations, and some of them disappear and some of them reappear. So this is the total number of amino acid changes found in 4,400 viral genomes that they sequence. And you can show where the longer the line means there's been more changes, but where they have shorter lines or no changes, if you can zoom in here, there aren't that many changes right there. For example, those might be better targets for a vaccine or a drug because it's not changing. It's an area that if it changed, the virus would not be able to replicate or make more copies of itself. So in the first American case, back in January 15th, that patient flew home from Wuhan to Seattle. His X-ray showed a little bit of uh, pneumonia. These infiltrates here, we call them pneumonia. This should be all nice and black. These lines are electrodes that were for heart monitoring that were placed on the outside of the chest. This is the stomach, and these are the diaphragms, and this is the heart. So that genome looked pretty related to the genomes that we're finding in Wuhan, and also in these other provinces too. So you can relate that virus from Seattle that was discovered to a virus in Wuhan. But then also in Seattle, 5 weeks later, a high school student developed flu-like symptoms and tested positive. But look at the changes. There's more changes. So this is a combination of old and new mutations, suggesting this patient did not acquire the coronavirus from somebody who recently arrived from China. Instead, the virus had been circulating and changing a little bit in the Seattle area. And so since then, viruses with a genetic link to the Washington cluster have appeared in at least 14 states, as well as the Grand Princess cruise ship. In California, there was a patient in Solano County, California, and look, only one mutation relative to the Wuhan virus. So this virus came from Wuhan. So there were 2 separate introductions from Wuhan that are documented here. There's probably many more that we don't know about, but this is just an overview. So, and then 2 healthcare workers got sick with a similar virus. So they got this virus from the patient in Solano County. And then there was a transmission from Shanghai to Munich. That was the first known European transmission from China. And you can see it looks a little bit similar to the Wuhan virus. So it probably went from Wuhan to Shanghai to Munich. And then genetically similar versions started spreading in Europe. Now New York. So you might have heard that the New York viruses probably came from Europe because this is one that came from Iran. That was the first case. Seems to be unrelated to the European strains, and there was no more transmission. But if you look at this map of New York, coronavirus infections genetically similar to samples circulating in Europe and North America, sort of yellow and darker yellow/orange are, I'm a little colorblind, sorry, are the ones from Europe, and these are other ones from Europe. And you can see there aren't as many from Asia and Oceania. So most of the infections introduced to New York came from Europe. So I just wanted to explain that, and this article goes on. I won't spend much more time on it, but to say that this is not really changing so fast as influenza does. So we will likely still have significant protection from this going forward. So that's definitely good news. So like to move on, and I do a lot of work with nursing homes, as you probably have heard. And can nursing homes dedicated to virus patients stop the spread? We're learning a lot about asymptomatic transmission in nursing homes and in the general population, so people who don't have symptoms transmitting it, but cohorting these people that are positive together is going to be important, and that's a lot of work we do. And interestingly, working with some schools now to help schools and businesses actually reopen and stay open once they're open. So it's an evolving field and quite interesting. Just a little bit of an update from the CDC. This is their site. I'm in the healthcare provider section, and what they're saying is that discontinuing precautions should now, if you're not testing for cure, you should actually wait 10 days. It used to be 7. They upped this to 10 days since symptoms have appeared, and add up to 3 more days since uh, significant recovery. So resolution of fever without the use of fever reducing medications, and improvement in respiratory symptoms. So they've extended that. This happened yesterday. So guidance keeps changing. And so we have to be flexible. I wanted to show this article in New England Journal showing that pre-symptomatic or asymptomatic, so before symptoms happen, uh, and this transmission has been occurring. And in fact, now I've been involved in screening several nursing homes, just testing everybody in there and finding that, wow, up to 30% of the patients or slightly less are positive, but they don't have symptoms. So a lot of elderly patients are positive and don't have symptoms. That's good news. To some, it's bad news in terms of infection prevention and preventing other people from getting the infection, but it's good news in terms of how we're, uh, most of us, even older people, are not getting sick from this infection or not getting that sick. This editorial on the same article from some actually colleagues of mine and my former mentor, Dr. Havlier, talking about the testing strategies that we should be implementing, and we should be widely testing. I know there's already a question about testing. It's not enough, but we're going to have to reopen, I think, despite that. So this is the article that came out last week in the New England, in the journal, in JAMA, one of the big journals. And I just want to remind everybody that in this article, they're talking about people presenting in New York with coronavirus, with COVID-19 disease, and 30% did not had a fever. Only 30% had a fever. Keep that in mind. And if you're looking at symptoms, Dr. Schweig was talking about oxygen saturation. So last week, a low oxygen saturation in 20% of patients presenting to the hospital for admission. So that's to be kept in mind. One other thing to point out is that this virus is affecting and infecting our lymphocytes. So the lymphocyte count, so in our body, we have different parts of the immune system, and white blood cells play a major role there. There are different types of white blood cells. Two of the major types we talk about are neutrophils and lymphocytes. And so in some viral infections like HIV, they predominantly infect lymphocytes. It seems that SARS-CoV-2 is also infecting and affecting lymphocytes. So a lot of patients presenting are having low lymphocyte counts. That's part of the immune response to this syndrome that we have to keep in mind. And that's probably a bad thing. One of the things a lot of people have been talking about also is oxidative stress. And we'll come back to that in a second, but oxidative stress is part of the reason that many people are getting sick. And the population that's getting sick are those with sort of diabetes or metabolic syndrome, the things we try to treat and avoid in functional medicine. But to point out that neutrophils are relatively high for a viral infection, and neutrophils they have this oxidative burst, so they give an oxidative stress for fighting infections, but it's not necessarily helpful in this situation where you're getting you're already having a lot of oxidative stress. And we know that people with diabetes in these conditions, they have a lot of oxidative stress already, and to get more from a neutrophilic burst, a burst from neutrophils, might not be a good idea. This is also, I wanted to just show you outcome data that these are hospitalized patients, okay? Most people with COVID-19 do fine, do really well. I want to say that up front and confirm that. But Once you're on a ventilator here, so invasive mechanical ventilation, once you're on that ventilator, you have a high risk of mortality. So uh, total discharged, total deaths greater than 65 on the ventilator, 41 percent. So quite high in some regards. If you increase that uh, age to more than 80, most of those died. Of those who did receive mechanical ventilation, so 88% of those who died had mechanical ventilation. So that's a major, that's a huge number, of course. So we want to try to avoid, and we're trying to develop strategies to avoid mechanical ventilation and to do it better for those patients. Some of us have friends and colleagues at the Buck Institute in Novato in Marin County, and they're talking about the immune system and aging. This is a post by uh, Eric Verdin, the president CEO, talking about basically diabetes and obesity as risk factors, as well as oxidative stress, and they're helping in an international effort for treatments on this. So I think that's a lot of good work. And I read his post today on LinkedIn. He was really talking about the obesity and diabetes being a major concern here. And as we know, it is. And that's why sleep remains very important. Sleep is an antioxidant. It decreases oxidative stress. And so we know we're always focusing on that. There have been a couple of questions about the relationship between the ABO blood group and COVID-19 susceptibility. Having an O type blood might put you at, uh, whereas blood group O is associated with a lower risk for infection compared with non-O blood groups. That's perhaps because type O has less of clotting factor called von Willebrand's factor. So that might be something there, because we're learning that part of this disease is not just injury to the lungs, but it's a clotting disease and disorder. Um, so nearly a dozen approved drugs could be effective. Keep in mind the data on hydroxychloroquine and some other things is not necessarily beneficial at this time. So there's a lot of things out there that theoretically should work, but might actually work, and they might not work, and they might cause harm. So we have to keep all of that in mind as we've been discussing. The big news was Gilead announcing results from the remdesivir study. Remdesivir is the medication that's been touted, and it's actually been on the shelf at Gilead. They tried it for uh, Ebola. It didn't work for that, but this study seems to show that remdesivir accelerates recovery from advanced COVID-19 disease, but this is not a panacea. This is not a huge difference. So this did not cure people. This was given late. There's a trend to difference. And just to put it into perspective, you'd have to treat about 28 people with remdesivir to save one life. So the number needed to treat is rather high in trying to save people. But it's encouraging. It's a positive step. We don't know anything about remdesivir in prophylaxis or early disease. It was used for severe late onset disease when a lot of damage, frankly, has already been done. So let's see if it's like Tamiflu or oseltamivir, which is used for influenza. If that's used earlier, we know the outcome is better. We have also a study, just as a counterpoint, this remdesivir study in China published in The Lancet on April 29th showed that there was no effect of remdesivir in this population. However, they had to terminate the study early because there weren't enough patients. So this is going to be a problem with vaccine trialing, and the group at Oxford is uh, ready to go with a coronavirus vaccine in phase 2, which is also great news from this week. So we'll see if depends where they study it. If they study it in China right now, they may not have enough cases. they're hopefully studying it, and I know they are studying it in different centers in Europe where there should be enough cases. But with the social and physical distancing, we have decreased the spread and then decreased the number of the people available to really get good data on this. And you can't ethically give somebody a coronavirus, a COVID-19 sort of infection. You'd have to let them be exposed in the community setting. So the more infections we have in the community, the faster and easier it will be to test a vaccine. That's interesting. And going back to the cardiovascular system, we know that there's a lot, again, published yesterday, a lot of implications on the cardiovascular system. We're finding that first patient I talked about last week who died in the Bay Area, that was the first American death from COVID-19 going back to uh, late February 6th, I believe. She died of a heart attack. So vascular problems, especially in people with chronic oxidative stress, is a concern and probably a risk factor. We're mainly talking about hypertension. I didn't show you the data from the JAMA article, the New York population, but hypertension was a major risk factor there. And people are asking, how does coronavirus compare to influenza? There's a article I just found in Life Science. And basically, influenza mortality, even in the bad year, seems to be much less than what we're experiencing from SARS-CoV-2 or COVID-19. But but we're learning more about prevalence. We talked about that, the serology studies last week that show that there might be a very high prevalence, meaning many people have been exposed to this already, which would mean that the mortality rate is actually quite low. So I don't think the mortality rate is alarming from SARS-CoV-2 infection. However, I think we need to be concerned enough to follow the guidance, staying at home, and keeping everybody uh, sort of up to date on the latest developments, news, hospital bed capacity, all that relates to getting back to business, opening up schools, opening up life again. It's going to be a rocky course, up and down, but I'm optimistic that if done correctly, we uh, will be able to get through this well. And we have some experiments now in this country. In Georgia, we're also looking at the experience in Sweden and other places that have, Denmark has started schools, and what's happened in China as well. So at this point, I'd like to open it up to questions. And I
Ramsey,
see,
I have a
uh,
quick question. You just touched on the Sweden example. Sweden made an interesting decision early on to, and maybe you can speak to this a little bit as well, but basically to not put as robust restrictions into place, but instead to ask people voluntarily to be conscious and careful and aware. And it did look like they had, a higher rate of infection and complication early on, but now there's a question as to whether they might be more quickly achieving herd immunity compared to the rest of us. What are you looking at there?
yeah, so, I mean, this is Sweden. I opened it up here on the healthdata.org website. Do you see this? These projections are that they're going to have uh, they have potentially a high volume of cases there. We don't know. This is ICU bed capacity. They are projected with this model to exceed it. And if you look at Norway, uh, right next door, they are, you know,
Mhm.
I don't know why they don't have projections available there, but they're not looking at exceeding capacity. So we're going to find out, and definitely there will be more herd immunity. I mean, remember we talked about that concept last week, but if you have 70 to 80%, even 50% will help you. The more of the more people that have been infected in the area and have recovered, they'll have antibodies that will cause protection against further infections. So, New York City, we're talking about a quarter of the population of New York City has been exposed. That's a major area of herd immunity. I'd love to see what the data is on Wuhan to see what the herd immunity is there. But in New York City, it seems to be quite high. And probably by September, that herd immunity will be maybe even hitting 40% in New York. So that will be substantial, but not enough to prevent overwhelming capacity at that point. So uh, somebody said a question about Governor Newsom saying that we would need to do a minimum of 60 to 80,000 tests a day to uh, in California to loosen restrictions safely. I agree. We are nowhere near that. And frankly, getting these tests, I've been on a few calls this week with helping facilities trying to get tests and see what the options are. It's challenging. Believe me, it's really challenging to get those tests. I think it's going to be a while before we have enough. Somebody's asking, is a history of multiple episodes of pneumonia, or does that history place somebody at higher risk of having problems with COVID? Perhaps. You have to figure out why you've had those pneumonias. In general, as an infectious disease or functional medicine doctor, we think of what are the risk factors. If somebody has multiple pneumonias, do they have an immunoglobulin deficiency? So we always look at that. And if you have an immunoglobulin deficiency, also you have to look at, are these pneumonias after a viral infection? So is it a pneumonia after influenza? If it is, that's different than uh, uh, a regular bacterial pneumonia that might or might not be associated with an influenza infection. So those are interesting.
And other risk
Uh,
factors also, is there a history of allergies that could be managed better, or history of asthma, either known or undiagnosed, that's causing some reactive airway disease with, impaired secretion clearing, et cetera, and or mold exposure. So also kind of digging into the environment to seeing, why those pneumonias are happening. If that person had pneumonias and then seemed to clear them pretty easily, or somewhat linearly with treatment, I think that would be less concerning. However, if there's more of a nonlinear path, or there's some head scratching going on as to why is this happening, or why is the treatment not working, that would skew more towards the higher risk side.
yeah, so I agree, and keep in mind that if you have asthma or even COPD/emphysema, those do not seem to be risk factors for COVID-19.
Hmm.
So not severe disease. So asthma and COPD might be risk factors for bacterial pneumonia, but they're not risk factors for COVID-19.
Which is
Getting a
reassuring.
question of
Yeah, which is reassuring. A
absolutely.
lot of people are very scared.
But
Like, if my lungs are a weak point already, is this going to be worse or more severe? Yeah, good point.
yeah, that's great. And then somebody's asking to revisit the data about the increase to 10 days of isolation uh, from 7. So this is, so CDC is saying symptomatic patients should remain in transmission-based protocol precautions until either 2 negative tests or 10 days have passed and symptoms have first appeared, and you might add on 3 more days to that. Tell you what, the rationale behind this, and I got this from some of our California Department of Public Health epidemiologists and physicians, that there is some data that's not yet been published showing you can culture a virus and you can detect it by PCR or a direct test for the genetic material. But when you do that direct test, you don't know if that virus is viable. We don't know if that virus can infect other people. But when you culture the virus, that's culturing for that's looking for viable virus. And there was a study unpublished that shows up to 9 days of culturable virus in a group of patients, but nothing cultural beyond 9 days, even when the PCR test was still positive. So that's the rationale for the 10 days for people with symptoms with start of COVID-19, having 10 days minimum from when symptoms started. And then if your symptoms didn't improve until day 14, then you'll add in 3 more days. So you could actually get, in that scenario, 14 plus 3 was 7. So you want to be isolated for 17 days. It's a little confusing, but it's at least 10 days and then 3 days from when symptoms have significantly improved.
So
So
Dr. Oscar,
hopefully that
how does
answers.
that dovetail? Yeah, thank you. That was good. How does that dovetail with the article that came out yesterday and earlier this week talking about documentation of shedding of the virus for up to 6 weeks? And so are you saying that possibly what we're looking at there is not necessarily live culturable viruses, but maybe more dead viruses that are not necessarily transmissible, or do we even know?
Yeah, so it's we're looking at potentially dead viruses, or viruses are never alive to begin with, but
Right,
it's
thank
possible
you.
that these are
Non-infective.
non-infective viral genetic material. And we know that happens with even some bacterial infections. One is C. diff. You can be PCR positive for C. diff for a long time after your symptoms have resolved. That's why we don't do a test of cure in C. diff. So there are some people that will shed virus for longer, and perhaps they will shed infectious virus for longer than others. We know this with significantly immunocompromised people. I'm talking about organ transplant or bone marrow transplant, recent chemotherapy, and they can probably shed viable virus for much longer. But yes, there's a lot of unknowns here. This is a reasonable uh, set of guidelines. And remember, we have to do, in the public health approach, you have to weigh lots of factors. So do you want to isolate everybody for 6 weeks? That would be horrible. You'd have no healthcare workers. You'd have nobody that's able to do anything. So you can't practically do that. So what can you do to keep the basics of our national system running and have a good public health strategy at the same time?
Yeah,
It's tricky.
yeah.
One good question about the reliability of the antibody tests that are now available through Quest and LabCorp. So keep in mind that if the prevalence of a disease, I think I said this last time, I forgot, but if the prevalence, so if there's less than 5% of us that have been exposed, and we do a test for a virus, even if it's a good test, if that test is 95% specific and the prevalence is less than 5%, most of the tests will be false positives. Most of the positive results will be false positives. So, and we also have other coronaviruses. I think LabCorp and Quest of these tests are relatively reliable. Interestingly, they're only doing IgG, partly to get a lot of more false positives than IgMs, but they're also only doing IgG so that they don't get people that are acutely ill coming in for these tests into their testing centers. So I would use, if I'm going to do an antibody test, I would favor Quest and LabCorp rather than the at-home brood tests, just because those are the big operators, lots of experience. They know what they're doing. They have quality controls. And we'll have to see what the data shows on their tests, though, with that caveat.
Great. So we'll transition in a minute over to Lindsay Ramsey. I just want to get your take on the last question there. On what is the chance that one of these coronavirus tests that are being produced for this current COVID-19 situation could pick up an old or a different coronavirus and still generate a positive result?
There's a high chance of that, and that plays into that whole false positive calculation. So
Yeah.
if you're in New York City, where the prevalence is 25%, and you test positive with an IgG antibody test, it's likely a true positive. But if you're in the Bay Area and you test positive with one of these tests, it's not as clear because the prevalence data we have in Santa Clara County, which was, by the way, the hardest hit in the Bay Area, that Stanford study said maybe 5%, 4.5%, maybe less. Again, we don't know the reliability. And the LA data also 4.5%. So that means unless that test is 99% specific, you're looking at most of the results being false positives.
Hmm.
So the test isn't super useful in California. It's not super useful. I want to know. I had a cough-like illness back in late January, early February. I want to know if that was COVID-19 or, but even if I get a test and it shows me a positive antibody, do I know? You know, maybe,
Yeah.
maybe. The answer is maybe. It's a definite maybe. I mean, this is where we are. So I know a lot of people want to get tested and want to know and want to know, and then I do too. Okay, I'm there with you. But the science doesn't support it. It just doesn't. So it's still reasonable to get a test. We can interpret it. We can discuss it. I have ordered this test on several patients now, both from Quest and LabCorp, and let's see what the results show. See if they had a compatible illness. But remember, at least half of people are totally asymptomatic with this.
Yeah.
So,
So that's the pretest probability. What is your clinical suspicion, just based on the symptoms that this person does have the illness, in this case, COVID-19. If they have a high pretest probability, then and you get a positive test, the chances that test is correct are greater. If you have a lower pretest probability, you're just sort of using this test as a screening test. What Dr. Asfar was saying is you have to have an extremely high specificity on that test in order to be able to trust a positive test as a true positive. So this gets kind of deep into statistics, but it's very important to consider. These are really important calculations.
The easy way that I think of that is that, take I pick on the good sisters, but if you take nuns, a group of nuns, and you test them for HIV, right, and you get you're going to get some positives because the test is not 100% specific. You're going to get some positive. Those are false positives. Okay, that population, the number of cases of HIV is incredibly low in that population. So any test you do is going to be a false positive. And it's the same concept that we're talking about here in this population. You have to have enough disease in the community to increase your pretest probability to make the value of the test true.
And that will shake out a little bit in the next weeks and months as it's a kind of a gold rush situation right now with imperfect vetting of all these tests, and so that will improve over time. We will get tests that are more sensitive and more specific as the better ones rise to the top and the worst ones fall to the bottom. So yeah, but as with everything, it's not a clear-cut answer. Last question before we shift over to you, Lindsay. If someone's been coughing for 2 months, can they still be transmitting the virus? What do you think, Dr. Asfar?
So I think it's not very likely. I think that the CDC recommendations are, that a lot are reasonable. If this causes irritation uh, to the airways, to the lungs, and people respond differently to that. Some people might have a persistent cough for 3 or 4 months after an infection like this. And in fact, there's a few people that I've known that treated for this that have had that persistent cough. I give them a short course of steroids, even oral prednisone actually, and that seems to have helped. So there's some ongoing inflammation that's post-infectious inflammation, and this is common in a lot of diseases. So I think it unlikely. I think that if that person who has a persistent cough had an improvement in the symptoms, an improvement in the cough, or resolution of fever, then you can use these CDC guidelines that I was talking about.
Yeah, great, wonderful. Thank you so much. That was really helpful.
You're welcome.
So with that, Lindsay, why don't you jump in and give us your thoughts for today?
Great. Let me see. Oh, okay. Starting my screen share.
Starting up. Yep, there we go.
I'll see
You're
that.
good.
Okay, great.
Yeah.
Okay. So this week I just wanted to give you guys a brief update on some cool articles I found over the course of this week relating to my usual topic, nutrition, or my usual topic in this webinar, nutrition and COVID. So there's some interesting research coming out, mostly through surveys, informal research, looking at how COVID is impacting our eating patterns and then our food system as a whole. So an article in Time Magazine's online kind of forum came out this week with some interesting facts about our eating patterns and COVID. There was a survey done by an organization I hadn't previously heard of before called Hunter Group, I believe. And they found a couple cool things. One is that web traffic for cooking websites is surging right now, which indicates that more people are cooking at home and looking for things to make. That's really encouraging, considering that at a baseline level, a lot of people are relying on takeout food in their day-to-day lives. So the survey included 1,000 Americans, which is a pretty nice number, and they found that approximately 50% of them said they were cooking more at home right now, and around 38% reported that they were ordering less takeout. And this is encouraging because previous research shows that approximately 20% of the average American's calories come from restaurant food, on a weekly basis. So if you're interested in reading that full article, I have it in the references section here, but this is the title of it right here. So there's also some downsides to how COVID is affecting our eating patterns. One is that sales of flour, sugar, and alcohol are surging. I don't know about you guys, but when kind of everything started back early March, the baking section of even the Whole Foods baking section was like one of the first areas to be cleared out. I know people are, baking is a fun thing to do when you have extra time, but consuming all that sugar and flour is not ideal right now for your immune system. That same survey I mentioned before found that people are reporting that they're turning more to comfort foods right now. That's a way that some people manage stress, not saying that it's a great way. And we did touch on that topic before, and I talked about how mindfulness and cultivating some mindful eating behaviors can help when you get those cravings for comfort food. So while people do appear to be cooking more at home, there was an important quote in the article. The relationship between cooking more frequently at home and a better diet doesn't necessarily hold true across the spectrum of socioeconomic status. So it appears to be, this relationship appears to only hold true for higher income households, which is concerning when we consider how nutritional status affects our immune system and our susceptibility to disease. So that was kind of a concerning finding. Overall, COVID appears to be widening nutritional disparities between different classes as well. And then this article points out that as restaurants are reopening in Georgia, we are in that situation, probably putting these restaurant workers at an undue risk, in the demand to get restaurants open again. They may be more likely to be exposed to COVID circulating around. So those are some kind of negative aspects of what's happening food-wise. And then also there's some interesting changes happening in terms of our food system as a whole. You've probably seen a couple articles circulating around this week related to impending meat shortages and Trump's executive order to keep certain meat processing plants open. This is concerning because meat processing plants, everybody's in pretty close quarters, and the risk of COVID being transmitted from person to person in there is pretty high. In terms of meat shortages in the store, a couple key points from this article in Time Magazine. They mentioned that grocery stores may have less meat available in the coming weeks, so that's something to be aware of. You may want to do a little prepping ahead of time, and I'll touch on that. Meat prices may also begin to rise as we experience a shortage here. And the shortage isn't due to a lack of meat, physically being available. It's because there we're not able to keep enough people in the processing plant to keep them processing the meat. However, meat availability may begin to improve by June as processing plants start to implement new strategies for keeping workers safe in that setting. So along those lines, we're realizing with this situation some of the issues with our centralized, food system, specifically as it relates to meat. So this is a good time to figure out if you can find some local farms near you where you may be able to kind of decentralize your food intake and find some other alternatives. So this article pointed out that community-supported agriculture is actually doing quite well right now. If you haven't done or participated in a CSA before, basically it's almost like you're buying a share in a farm and then you get some of the produce over the course of a growing season from that farm. And I live in the Boulder, Colorado area, and we have a lot of CSAs out here. And I was thinking this week, I ended up signing up for one. If you are concerned about meat shortages or fluctuations in the availability of other foods right now, joining a CSA would be a great thing to do if you have the bandwidth to do that right now. So included a couple links here to websites where you can find CSAs and other local farms near you. One is Eat Wild, and then the other one is called Local Harvest. So just to wrap up here, a few key takeaways. One is I would highly encourage you to check out CSAs near you, see if you can find one. And that way you can not only get really high quality food, oftentimes they'll have meat, eggs, and a variety of produce, but you can also kind of, on an individual basis, move away from our really centralized food system. Another thing you could do, and I'm considering doing this as well, is if you have the resources, either donating time, money, or food, depending on where you're located, to people who may be running short on food right now or not have as much access to high quality food as others. And I included a link here to a website called Feeding America, where they offer some options for people who want to get involved in helping others get access to good food at this time. In terms of the restaurant situation, to help keep restaurant workers safe, I would suggest that if you're going to eat restaurant food, order it through DoorDash, order it via takeout, so you're not going into a restaurant and getting in close contact with others. And of course, try to pick healthier food rather than, fried takeout food. And a couple other last things, if you've begun cooking healthy meals at home, keep up the good work. Obviously, this is a trend. We're noticing on a grander scale, a lot of people are cooking more at home. And then finally, another way to kind of boost your self-sustainability is start growing some food at home, if this is something you have the space for. So if you have a yard, you could consider getting started with some simple potted vegetables, like tomatoes are pretty simple to grow, things like that. And a lot of home and garden websites have really nice instructions on how you can get started with a garden right now. And then if you are in an apartment like me, or you just have limited space to grow things, you can even grow some food indoors. One you could do is microgreens. I included a picture here of the ones I'm growing, which are basically like baby versions of broccoli and kale and other veggies. You can easily do that indoors. And I included a link here to a website called Back to the Roots. And they sell a bunch of different indoor DIY growing kits for different vegetables. They have tomatoes, a variety of peppers, and some other cool plants in there that you could try growing yourself. So that's everything I have for you today.
Great, thank you, Lindsay. That was super helpful. So just touching on a couple of points that were raised, for those of us who do eat meat and are curious, or also just want to support more local food sourcing. I have a friend actually from middle school when I was in 6th, 7th, and 8th grade, David Evans, who now runs Marin Sun Farms out in West Marin. And they actually do have available the ability for people to call and order bulk orders of a variety of different types of products if you're interested. They'll deliver them to you either in a non-frozen or frozen state, individually plastic wrapped. So if you have extra freezer space, you can keep those on hand. Super high quality, hyper local food for us here in Northern California. My contact there, if you're interested, her name is Alexis, Elexis, Alexis Scott. Cell phone 415-653-9288. Email is escott@marinsunfarms.com. And these do sell in pretty large bulk quantities. So either have extra freezer space or have a few friends who you want to divide this up, or family members. But just a good resource for you there. And in terms of the oxidative stress, we've touched on a lot of those factors. I think that was a great point that Dr. Asfour brought up. Oxidative stress is a critical pathway that is necessary for life and for health. However, it is one of the primary pathways that can get out of balance and hyperreactive in a variety of different chronic and acute health conditions. And there's a lot of ways that we can modify those pathways. So diet, glycemic control is a super big one. So like Lindsay talked about, being a little careful, maybe not doing all that baking and having that sugar, trying to eat a nice balanced, healthy, mix of protein, fat, vegetables, and some carbohydrate, but, reaching for the healthier carbs, the potatoes, sweet potatoes, taro, rutabaga, turnip, all the root vegetables, etc., and less of the flour processed, baked goods. We call it the white menace, avoiding the white menace, right? White sugar, white flour, all the really simple carbohydrates that cause a spike of blood sugar that's makes your body respond with a spike of insulin, and then you're off to the races in terms of inflammation. Insulin, which chases that sugar, is actually one of the most inflammatory hormones in the body. So balancing blood sugar is a critical intervention for almost any health condition. Diet rich in phytonutrients, berries, and then all the other things we've talked about, sleeping, moving the right amount, meditation, antioxidant support in terms of supplements, things like glutathione, alpha lipoic acid, vitamin C, we've talked about a lot in these discussions, curcumin, EGCG from green tea, either drinking the tea, probably the best way to get it, or also taking a supplement. If you want to have some of the benefits of green tea, but you don't want the caffeine, you can take a green tea bag and boil your water, put the tea bag in the teacup, pour the water into the teacup, let it steep for 1 minute, and then take that water and dump it out, and then put the tea bag back in the teacup and pour more water in and steep that, and then drink it. And by steeping it for a minute, dumping that water, you actually dump a majority of the caffeine that has in it. And so it's a way of getting some of those healthy compounds without necessarily as much caffeine. N-acetylcysteine we've talked about, also B vitamins, zinc, etc. So just a quick rundown there, reminder, tying it together to some of the antioxidant and oxidative stress pathways. We're going to switch over actually to Valerie if you're almost ready. Nick informed me that he is not available to be with us today. I actually am collaborating with Nick and building out an online Qigong curriculum that will be available to all of you, to our patients and clinic. So he texted him and said, hey, I didn't see him on the program today, and he said, oh, sorry, I lost track of time. I'm out in the Redwoods filming right now. We just got involved. So he's doing good work, and will be with us, I hope, next week. And right before we switch to Valerie, I'm going to do one quick update on the family chicken farm. As we were talking, we did have another arrival. So we're going to do a little live. This is like as we're speaking, folks. So check this out. Watch this. Look how quickly the firstborn chick heads over there to provide either a welcome or some assistance. My son told me that prior to the hatching, the first chick was actually helping to peck at the egg. He looks pretty happy to see his sibling. It's cool to see the difference also of a chick that's been out for a couple of hours compared to one that just arrived. The first chick is definitely way more animated. It's a really exhausting process, obviously, for them to make it out, and some don't, but these guys are doing great, but they end up laying there for a while and just kind of adjusting and breathing and stretching, and you can actually hear their cheeps, cheep, 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 before they're out of their eggs. You can hear them inside the egg cheeping sometimes. Good stuff. So, all right, Valerie, take it away.
Okay. Well, congratulations, Dr. Schwag, on the new members to your family. That's great.
It is very
Especially
exciting.
the timing on the 1st of May. That's really quite wonderful. Appreciate seeing that, you know.
Yeah.
Yeah. Well, as promised, we're going to talk about sleep today and getting a better night's sleep. Dr. Schwag, Dr. Ashford, and all the other experts agree that getting a good night of restful sleep is critical to building and strengthening our immune systems. So, of course, the dilemma is that when we're under a lot of stress, we most need good sleep. But when we're under a lot of stress, we're usually least able to attain it. So today we're going to use mindfulness skills to cut through that paradox and improve your ability to drop into a deep night of restful, healing sleep. So the psychojargon for what we're going to be doing is called anchoring and amplifying a state. So a state, first I'm going to explain those 3 terms because I really like for you to know what we're doing and why we're doing it, as well as enjoying the experience of deep relaxation. You know, a state is a specific neurochemical, physical, emotional, mental condition that's specific to any given situation. When you're under extreme stress, you're going to feel very different, and that'll be reflected in, you know, blood, urine, saliva, brainwave scans, and so forth. You're going to feel very different than if you've spent a couple of weeks lazing around on a tropical beach. Your neurochemistry, your emotions, your state of mind, your mental clarity is going to be very, very different. And what we're exploring today is the state of drifting off to sleep, just that tipping point, that moment, that elusive state when we go from wakefulness to sleep. Now, the problem with that state is A, it's very, very short and brief, and B, we're just about ready to fall asleep, so we don't remember it very well. And amplifying is what we're going to do so we can remember it, recall it, summon it at will with our sensory brain, less as much as our conscious, mindful brain. And anchoring, the 3rd term I'm using, and you know, amplifying and anchoring a state. An anchor, think of a ship tossing an anchor overboard to tether it to a specific place. An anchor is a sensory cue that tethers our conscious mind to a specific unconscious state, such as falling asleep or deep relaxation or the wellspring of our creative drive. So that's what we're going to do today. So the first thing to know is, oh, and I should add, what we're also going to do after we explore this state, we're going to amplify it by slowing down those 2 to 3 seconds when we drift, when we pivot. We're going to slow them down and stretch them out to 2 or 3 minutes today. So we really, truly get them and understand them and can easily, through amplification, find our way back. And we're going to anchor it as ever with the breath and with some prompts and cues that I'm going to give at the end. I'm going to recite a common list of pre-bedtime habits, like brushing your teeth, and I'm going to anchor the suggestion that those habits are a series of prompts to your unconscious mind to better prepare for sleep. Because sleep prep can start as soon as the late afternoon and actually even earlier. So that's what we're going to do. So let's settle in as we always have been doing. Get your feet on the floor. Make sure the door is closed. Your phone is turned to silence. If you have anything on your lap, please put it aside. If you have anything in your mouth, chewing gum, mints, that kind of thing, it's a good time to take them out. And also, if you are knowing you're going to relax, why don't you get settled into that position first? You know, if you know your head is going to fall back, get the pillow really comfortable there right now so you can enjoy this experience even more. Okay. And Dr. Schwag, I'm wondering if at this point you want to take blood pressure, or if you're done with that type of experiment, heart rate, I should say, or
Sure,
if
yeah,
you need to do that.
Let's do
Okay.
it. I always
Now
enjoy it.
would be a good time to start that as people settle in.
Wonderful.
Great.
So for today, there was a little bit, maybe a little bit of confusion last week when we did the measuring and then the recording, you know, in real time. So for right now, if you have just a piece of paper, just write down the values next to you, and then we'll send a link at the end. You can enter in your data. So, you know, write down before, and then again on a scale of 1 to 10, just write down how stressed do you feel. 1 is no stress, and 10 is extreme stress. So on a scale of 1 to 10, how stressed do you feel right now? Great. And then we're going to measure our heart rate. So again, fingers on your neck or on the thumb side of your wrist, 2 or 3 fingers, you can feel your pulse there. And once you have that, when I say start, you can go ahead and start counting, and I will tell you when to stop. On your marks, get set, go. And stop. Okay, so write that number down and multiply it by 2. That will be your heart rate per minute. Save those, and we'll log our final numbers and then put them into the survey at the end. Thanks, Valerie. Go ahead.
Okay, wonderful. Thank you for including that. So once again, settle in, get calm, make sure your hands and lap are unencumbered, unfettered. And if you feel comfortable closing your eyes, please do so. If you don't, just look down quietly at your lap or hands is fine. And begin by taking those slow, deep, diaphragmatic breaths that work so well to bring you mental clarity, emotional calm, physical ease, and relaxation. Breathing in through your nose as slowly and steadily as you can, and lightly. No need to push or work hard. And exhaling tension, breathing out through your mouth, feeling the air flowing out over your lips, squeezing your diaphragm muscles to push out every last bit of stale oxygen. Inhaling ease and relaxation as your mind becomes more focused and alert. Breathing in life-giving oxygen, exhaling release, letting go. Breathing in ease and nourishing oxygen into every cell of your entire body. In through the nose, out through the mouth, gently, slowly, which automatically focuses your mind as your body lets go with each out breath into peace and calm and security. More and more automatically with every breath you take. And as your mind becomes more alert and your body feels more at ease with each easeful breath, each breath more comfortable, bringing comfort and ease to your whole being. Each breath releasing tension and breathing in comfort and contentment. And allowing yourself to accept this. Breathing in through your nose and out through your mouth. Mind alert as you relax more and more into your center. And by that I mean simply becoming aware of the core, your physical core, deep in your gut and spine and belly. Settling even more with each easeful breath of nourishing oxygen, settling even more into your body, into your own skin, letting go of tension, centering down, breathing in ease and clarity. Now we're going to explore an image of a memory of when you fell asleep. It could be from last night or from a really delicious nap that you had. It could be a memory of when you dozed off in front of the TV. Doesn't really matter. Just pick the first memory that jumps into your brain. That one is just fine. And see it in the kind of the inner computer screen of your mind's eye. Just see yourself right before you fall asleep. Notice where you are and how restful it was to drift closer and closer to that tipping point of deep sleep. And simply become that image. Slip into that so you're now the first person. You can feel your cheek or the back of your head on the pillow, which is so relaxing. You feel yourself stretched out or curled up, doesn't matter, as you relax even more. And as your eyes are closed, you're aware of the darkness in the room surrounding you and any ambient sounds which are so soothing and allow you to drift asleep. This feels so good, so very good. Perhaps you have cushions or blankets and you feel the warmth of that, which is so relaxing, so easeful as you drift closer and closer into that tipping point of sleep. And now you notice how your thoughts are calming down. Your thoughts are kind of like an excited puppy or kitten that you hold in your arms. You just gently stroke and pat until your thoughts fall asleep in your arms. Just so easy to do. Or perhaps your thoughts are more like that young puppy circling around, slower and slower, making circles before they drop down into a restful snooze. And as your mind slows down away from thoughts, it flows to what's far more interesting and useful, which is your sensory awareness. So even more, you notice the warmth and texture and weight of the blankets. It relaxes you even more. Even more, you're aware of how heavy your body feels as you prepare for sleep. Because now we're in that 1 to 3 second window, which is going to stretch out like luxury before us. You feel your eyelids heavy, your sensory awareness slow and comforting. You feel how heavy your whole body feels, right into that tipping point, which is stretching out in slow motion. You're aware of your breathing shifting in a way that promotes sleep. Yes, your breathing pattern downshifts and slows down automatically and easily into deep, slow breathing, which is so restful because now you've been in a state of light sleep for a few minutes. Your whole body feels warm and heavy, and your outer senses, your external senses, close the shutters, close the shades on your external senses as you float gently and easily within, down a clear path that you see before you, this clear sensory path of warmth and heaviness, of total ease in your body, feeling the soles of your feet, the top of your head heavy and warm. And down that clear path, you feel how your mind opens into peaceful, sweet, healing silence, which is what you want. And it's before you now. You simply are so at ease, having your mind be absorbed into the deep, peaceful sleep. And you welcome this. Your mind and body agree this is desired, this is what you want. It's clear to you now. Your senses lighten and let go even more and become absorbed into the sweetness of healing silence, of deep, restful sleep. And all of your body mind wants this and agrees that this is absolutely the way to go, the way to be. So the pathway, the sensory pathway to deep, restful sleep is open, easy, clear, and direct before you. There's no confusion anymore. There's no getting lost off of this sensory pathway. And it feels so good to know that this is true, this is real. So that every time your head hits the pillow, you'll automatically take a deep breath and relax into the sweetness of feeling your body so heavy, so relaxed, that you flow down into the sweetness of silence and deep, restful sleep. And it feels so good to know that this is real, this is true, so that every time you think about bedtime, you'll automatically relax as your body-mind prepares for a full night of deep, restful sleep. And whenever you check the clock for bedtime, you'll take a deep breath and automatically prepare to drop into this state where your mind is easily absorbed into healing peace of silence and deep sleep. It feels so good to know that every time you turn off the TV or your computer, you'll automatically take a deep breath as your body-mind prepares you for this pathway down into sleep, which is so healing and restful. And every time you say goodnight to others, you'll take a deep breath and automatically orient towards this portal into deep and restful sleep. The warmth, the heaviness, the silence. And every time you check the locks on the doors or the kitchen burners before bedtime, you'll automatically take a deep breath and orient towards relaxing into this sensory flow of feeling the softness of the pillow on your cheek, the warmth of the blankets, which triggers deep healing sleep. Every time you turn off the lights, you'll automatically go to the state of being absorbed into deep, restful, sweet sleep. Every time you turn down the thermometer, yes, you'll automatically relax into a state preparing you for deep, restful sleep. And whenever you step into your bathroom, that's right, you'll take a deep breath and automatically prepare to drop into a deep state of healing sleep when your head hits the pillow. Whenever you brush your teeth, you'll automatically take a deep breath, perhaps at an unconscious level, which cues your body-mind for what you most desire, resting into this space of deep healing peace where your mind is easily absorbed by restful sleep. Every time you wash your face or put your pajamas on, yes, you'll take a deep breath and automatically prepare to have a full night of healing sleep. Every time you turn off the lights, that's right, you'll take a deep breath automatically and easily as your body-mind cues you to prepare for a full night of restful, peaceful sleep. And every time you pull up the blankets, you'll take a slow, deep breath as your body-mind cues you to slide down that sensory pathway where your mind is easily absorbed by the peace and silence of deep, full, restful sleep. And that's right. Every time your head hits the pillow, you'll automatically take a deep breath. And the sensory pathway of warmth, of heaviness, of a heavy head and body, of your eyelids feeling warm and heavy, the peace and warmth surrounding you, the darkness, all allow your senses to flow down that direct pathway to the sweet silence where your mind is absorbed into a full night of deep, healing sleep. And it's so good to know that this is true, that this is real, that this really will happen easily and automatically. And for now, you know that this is true. And for now, that you've set the anchor and amplified the state that you most desire, that your body-mind is eager to cooperate with providing for you, you can now take a deep breath and allow this experience to fade into the background where it will continue to build and construct itself. But for now, that fades into the background. Will you return your senses to this room, this place, taking all the time you need so that when you're ready, you can open your eyes, wide awake and alert, feeling refreshed and feeling good.
That was awesome.
Hmm.
Makes me want to go take a nap.
Well, if any of you fell asleep, that's great. Don't worry about it. You needed the extra rest. So we've set up amplifying this elusive 1 to 2 second state where you drift into sleep. And we stretched it out into several minutes. And then we anchored it to a series of suggestions which will continually prompt your mind through the evening to prepare for this. Because usually our thoughts are scattered, our mind is scattered. And we begin to coalesce almost too late, so we need to start coalescing our thoughts, patterns towards sleep much earlier in the evening. And that's the series of prompts that were set up. And enjoy them, watch them happen. The more you listen to it, again, the stronger this response will become. So by the time you're ready to sleep, you are totally prepared. And that pathway to that elusive moment will be so clear before you because you've anchored it by listening to this today. So that's it. Any questions, reflections, thoughts?
Let's do a little data post reading.
Mm-hmm.
So everyone, if you just want to write down again, this you can say after on a scale of 1 to 10. how stressed do you feel right now? And again, we will measure our heart rate either with your fingers against your neck or on the wrist side, the thumb side of your wrist. Once you have that fingers there, we will go ahead and start. On your mark, get set, and go. And stop. So take that number, multiply it by 2. The link, Christy, if you can put the link for the survey into the chat box. And then also it's on our webpage, ccfmed.com. Click on COVID-19, green button on the upper right, and down the bottom is the survey. Go ahead and enter your pre and post readings. And yeah, that was really, really wonderful sleep meditation, Valerie. I've been doing a lot of little audio sleep meditations lately. I've just had so much, been so busy and working hard and thinking through a lot of big picture projects that my mind is so busy by the time I try to go wind down and go to sleep. And I think what we can do actually is we could take the audio of that whole session, just that session alone, and isolate it and allow people to download that so that you don't necessarily have to be on the website, listening to the Zoom recording. You could probably have an audio file that you could download and have on your phone, so you can turn off your Wi-Fi and connectivity. And if you'd like to listen to that for playing with when you go to bed, you can experience that during this week.
Yeah, that would be a great thing to do a few times. The nice thing about this one, it was particularly short and sweet, so it's not going to take much time. And it involves a lot of post-meditation cues or prompts that will kick in automatically. So this will become effortless as your mind entrains to what we've been doing today. So that's nice. It becomes effortless very quickly. And I'm going to post my email. If anybody has any questions or wants further coaching and how to fall asleep, I'm more than happy to give you a free 15-minute consult. Since I used to teach sleep management at John Muir, being a lifelong insomniac myself, I've had to do a lot to learn how to manage it, and I'm happy to share everything I've learned with you. So feel welcome to drop me a note and set an appointment time.
Great. Yeah, so it's there in the chat box, everyone. ValerieJKeim@gmail.com. ValerieJKeim@gmail.com. And her website also is ValerieJKeimTherapy.com. So if you have more questions or thoughts, want to get more information, those are available. Wonderful, wonderful. Thank you, everyone. It was good to be with you today. Stay tuned. Next week, we'll probably have a whole pack of little busy cheeping chickens to show you, and I look forward to that. I hope you guys stay safe and healthy out there. And thank you so much for joining us today. We'll talk soon.